So I would just like to welcome Dr. Tim Trinidad. Okay. And you need to listen to his lecture. Okay? One of my favorite lectures.
Masyadong binibuild up. Okay, first of all, I'd like to thank my boss in the in the council, Boss Percy Ponsal. Okay, thank you for making me part of this program. Okay, so we go to the third objective, which is written in this slide. And I have no disclosure except that I'm the second most senior member of the council. And you guess who's the most senior? He's seated on my left. Okay. Okay. So what I intend to discuss are these bullet points, perhaps for the next 30 to 45 minutes. I hope that's the maximum, 45 minutes. So are you ready to bomb it? Okay, so we'll be talking about physiology of the cardiopulmonary exercise testing. So the CPET is similar to the cardiac stress test, but we use a special device as mentioned by Bernice, okay, known as a mass flow sensor, gas analyzer, and the pulse oximeter. And because of this, we can measure these parameters, which we try to plot as we challenge the patient to a gradually increasing work rate. Okay, so we are going to discuss these 9 graphs. Keep calm, kaya natin to. Okay, sige. Accept the challenge. So in CPET, we challenge the patient to a gradually increasing work rate. And for it to be useful, you should max out the patient. Okay, and one of the hardcore parameters that we measure is work rate maximum. We measure in the bike in watts and the VO2 max in liters per minute. Now, these parameters, just like FEV1, is dependent on the subject's demographic data. Okay, so you're younger than I, so your predicted work rate maximum and VO2 max will be much higher than me. Okay, likewise, the predicted values are dependent on health, particularly the cardiovascular, respiratory, prior experience such as training, and tolerance to symptoms. Okay, so a little bit again what Bernice mentioned, we divided to several stages. We have resting, wherein the subject is just going to sit on the bike. Then we go to the active baseline wherein he starts pedaling with no load for 2 to 3 minutes. Then we have to the incremental exercise test where he continues to pedal, but this time the bike is going to be loaded, such as by 10 minutes, he's going to reach 100% of his predicted work rate maximum. Ideally, the protocol should be, he should max out within 10 plus minus 2 minutes. So for example, we have a subject whose work rate maximum is 100. He should max out at 10 minutes at 100. So the incremental protocol is 10 watts. It is increased 10 watts every minute. So for example, it is 220 predicted. He should max out 220 at 10 minutes. So the protocol is we increase the work rate 22 watts per minute. So the test is stopped upon request of the subject or endpoints are reached as mentioned. And during this recovery phase, he continues to pedal with no load for the next 3 to 5 minutes. Okay, so here are the graphics, which is very important in the interpretation. X is time, Y is work rate. For example, the patient's predicted work rate maximum is 220. So the patient goes into unloaded stage. Then we challenge the patient with an incremental workload. And what's the incremental workload? It's supposed to be 22 watts per minute. So that by 10 minutes, it's 220 watts already. So the loaded exercise stops upon request of the subject and endpoints are reached and the subject goes into the recovery phase. And usually we present this in a graph wherein the x-axis is time and or the x-axis may be percent of the predicted work rate maximum. And when I present a graph, this is what we're going to talk about subsequently. Okay, so in this test, in this COSMED CPET, it is color-coded, the report. So you have the resting, you have the baseline, active baseline, you have the incremental in green, then the recovery will be in yellow. Okay, so let's discuss further the graphical representation of the test. So again, X is time, Y1A is the power or the work rate. Okay, this is the expected work rate for the subject, for example. And we challenge the patient with a gradually increasing work rate of 22 watts. So by 10 minutes, he's maxed out. Okay. And the x-axis, we can either use time, the work rate in actual values, or the work rate in percent predicted maximum. That's 0 to 100%. So this is an example of the monitoring sheet that we use in our institution. Okay, you have the different stages wherein we measure the work rate. We record the vital signs, the exercise tidal loop, and the Borg scale. So we do that at some stages, and we do it more frequent during the exercise testing. Okay, depends on the frequency what you're trying to find out. Okay, so let's go to the O2 consumption, which is one of the hardcore parameters. Okay, so 1YB is BO2 in ml per minute. That's the estimated BO2. If the subject is normal, he's supposed to reach this shaded portion over here. So this is the normal tracing. Notice that with increasing work rate, there's increasing BO2. Why? Because the source of energy, ATP, comes from aerobic metabolism. And you notice it peaks at around 80% of the work rate maximum. Okay, this is how it looks like when you print the report later on. X is time. Y is BO2. That's the predicted BO2 max for the subject. And you can see here, the blue one is the BO2. Okay, it did not reach the BO2 predicted for the subject. So by just eyeballing the graph, you know the exercise tolerance of the subject is poor. Okay, so in order to exercise, the muscle needs energy. Okay, to exercise, which we measured in watts in a bike, we need energy. And the source of energy is the oxygen from aerobic metabolism. And that oxygen is derived from the respiratory system, which oxygenates blood. And that oxygenated blood is transported by the cardiovascular system into the muscles, where it's utilized to produce ATP. At the same time, it produces carbon dioxide. And that carbon dioxide is subsequently eliminated by the same system involved in the delivery of O2. So for you to exercise properly, we need the respiratory system, which is going to oxygenate and remove carbon dioxide from our blood. We need the hematologic system, which is going to carry these gases. We need the cardiovascular system, which is going to deliver these gases. And we need the muscle to be able to use that oxygen and convert it into ATP. So basically, during exercise, we increase our minute ventilation, both the tidal volume and respiratory rate, and we increase our cardiac output, both our stroke volume and heart rate. We just analyze the changes in these parameters, and that's how we interpret what is the cause of the shortness of breath of the patient during exercise. So let's go to the cardiovascular response. Okay, the heart rate is the highest achieved dependent on the age of the subject. So for you, you're in the range of 30 years old, your heart rate maximum is around 186. Our president, Dr. Janet Samson, okay, what do you think is the heart rate maximum? Higher than 186, lower than 186? Estimating ko, okay, based on her looks, mga 170 na. Okay, sige. Normally, the heart rate is achieved at 100% of the predicted work rate maximum. Sometimes there's a heart rate reserve na 15 at maximum exercise. Now, the stroke volume increases gradually with increasing work rate and plateaus near normal, near peak exercise. We cannot measure stroke volume during CPET. So we use a surrogate, which is the O2 pulse, BO2 over heart rate. So this is the heart rate and O2 pulse response in a graph. Okay, Y1 is heart rate. Okay, that's the predicted heart rate maximum for the subject. And you can see that the heart rate increases with increasing work rate and reaches a peak max at 80 to 100% of the work rate maximum, and it plateaus thereafter. Now, in the Y2 axis is your O2 pulse, which is the surrogate for stroke volume. And you can see this, the shaded portion, that's a predicted O2 pulse for the subject. If he reaches that, that's a normal stroke volume. And you can see that the stroke volume gradually increases with increasing work rate. It maxes out at 60 to 70% of the work rate maximum. then plateaus thereafter. So both the heart rate and the O2 pulse stroke volume increases with the work rate. But the O2 pulse, the stroke volume, plateaus earlier. Here is how it looks like in actual report. X is time, Y is heart rate, Y2 axis is your stroke volume. That's the predicted heart rate maximum. That's the predicted BO2 BO2 over heart rate or your stroke volume. Okay, you can see that the heart rate max out, the maroon reached the predicted. Okay, but the BO2, the stroke volume, did not reach the predicted here. So it's a little, you can still consider it normal based on this tracing. Okay, the complicated one is the Fick's principle. And Fick's principle states that the O2 consumption is the product of your heart rate times stroke volume and the difference between your arterial O2 content and your mixed venous O2 content. Basically, the Fick's principle is telling us that the amount of oxygen that you can use, okay, to exercise is dependent on the delivery of O2 to the tissues and the ability of the tissues to use oxygen, these two parameters here. Okay, so let's discuss the O2 over heart rate, which is our surrogate for stroke volume. Okay, if we assume, okay, these parameters are normal, okay, we have a normal relationship between the BO2 and the heart rate. You get it? Pag normal to, normal to. Okay, if the stroke volume, either this one decreases or your difference between arterial and mixed venous O2 decreases, okay, the heart rate needs to compensate. It's going to go higher and therefore the O2 pulse is going to be lower. However, if you have a high stroke volume and your muscle can extract oxygen, such as in athletes, okay, they're going to have a high BO2 heart rate values. So this is the heart rate BO2 relationship. X is O2 consumption, Y is heart rate. That's predicted maximum for the subject. That's the predicted heart rate maximum. And that's the normal BO2 heart rate slope. Okay? So the increase in heart rate, the increase in your BO2 heart rate should fall within this shaded area here. If it falls outside that shaded area, that's an abnormality. Okay, so this is how it looks like. BO2 in the X, heart rate in the Y1 axis. That's the predicted BO2 max. That's the predicted heart rate maximum. That's the pathway of the heart rate BO2. And you can see that if you try to look at the maroon, which is the heart rate BO2, it reached the predicted, but it is outside the predicted pathway. So eyeballing, you know, it's abnormal. Okay, the source of energy when we exercise, okay, which we measure in watts, the source is ATP, and it may come from either aerobic or anaerobic metabolism. What will determine if you're going to use aerobic or anaerobic metabolism will be the O2 delivery to your muscles. If the O2 delivery is adequate, you're going to use aerobic metabolism. But if it becomes inadequate, you're going to recruit the anaerobic metabolism. Notice that during aerobic metabolism, we use oxygen, we produce ATP, but we produce carbon dioxide. Now, during anaerobic metabolism, we don't use oxygen, we produce ATP, but we produce additional carbon dioxide and hydrogen lactate. And this principle is very important on how we recognize anaerobic threshold non-invasively. Okay, so what are the sources of energy? Aerobic and anaerobic. Okay, and in aerobic, we produce oxygen and carbon dioxide, but in aerobic, we don't use oxygen, but we produce carbon dioxide and lactate. So these are the sources of energy during exercise. X is percent predicted work rate maximum. Y is the ATP in percent predicted of the maximum. So initially, the blood flow is adequate. During initial exercise, we use aerobic metabolism. Subsequently, because of the increased O2 demand, okay, we recruit, the blood supply becomes a little bit inadequate, so we recruit the anaerobic metabolism. The time when we start recruiting anaerobic metabolism to produce ATP is known as your anaerobic threshold. Okay, So that can be determined by your BO2 and BCO2 during exercise. Okay. So during aerobic metabolism, there's continuous O2 consumption with increasing work rate with a continuous proportionate carbon dioxide production. But once we use the anaerobic metabolism, what do we additionally produce? We additionally produce carbon dioxide and hydrogen lactate. So this is the B-slope method in determining anaerobic threshold. Okay, X is BO2 in predicted maximum and Y is BCO2. So initially, during exercise, wherein we're using aerobic metabolism predominantly, there's a carbon dioxide increases proportionately with the oxygen. But at the onset of anaerobic threshold, there's an additional carbon dioxide that is produced. That's why the slope is going to change. Okay, so this is how it looks like in the graphs of this CPET, B-slope method. X is O2, Y1 is Y1YB is BCO2, predicted BO2 max, predicted heart rate maximum. So initially, there's a linear. This slope is for CO2 increases proportionally with the carbon dioxide. Notice the change in the slope. That marks the transition. The slope marks the anaerobic threshold. Okay, at anaerobic threshold, there is increase more in the carbon dioxide increases more than the oxygen, and therefore you have a steeper slope. The anaerobic threshold, usually the onset is around 40% of the predicted BO2 max. Okay, 40% and above of the predicted BO2 max. So X is BO2, Y2 is carbon dioxide. Okay, that's the first slope, carbon dioxide. You notice that. And where's the second slope? That's the second slope. So the anaerobic threshold occurs here at 678 of the BO2. So the red BCO2 change slope at 678 BO2. And the anaerobic threshold is approximately 40 to 50% of the BO2 max. Dapat yung onset niya nandito sa 40 to 50%. Now, there are several ways in determining AT by other methods. The principle is there will be an increased carbon dioxide more than the oxygen. So this increases the RER or the RQ. There will be an additional increase in the BCO2, which stimulates increase in minute ventilation. And the manifestation is there will be an increase in tidal O2 and an increased respiratory equivalent for oxygen. Okay, so RQ method. Okay, increase BCO2 over BO2 will increase the RQ. X is time, Y is RQ. Can you recognize where the anaerobic threshold is? Okay, that's the anaerobic threshold. Okay, second, by BE method. Okay, additional increase in BCO2 stimulates increase in minute ventilation. Time, minute ventilation. Can you recognize where the minute ventilation increases here? Okay, it increases at this point here. Third, okay, the PET O2 method. Okay, there will be an increase in PET. X is time, Y is end-tidal O2. Can you recognize? It's in blue. Okay, notice, bumaba muna, tapos tumaas dito. So that's the onset of anaerobic threshold. Then finally, we have the BE-BO2 method. Okay, X time, Y2 is equivalent for BO2. And you notice that there's a change in the slope towards this one, again, marking the onset of anaerobic threshold. But the most reliable is your B-slope method. Okay, so what again are the methods? You have your B-slope method, you have your RQ method, then you have your BE method, you have your VE-BO2 method, then you have your PET-O2 method. Okay, let us now go to the respiratory responses. Okay, as mentioned, you have your maximum voluntary ventilation. It is the highest ventilation that a subject can generate. Have you seen 1 NBB during spirometry? Some institutions still does that. Okay, or it can be calculated as mentioned by Bernice by FEV1 times 40. Okay, So that's the BE. Let's see the BE response. X is time. Y1 is minute ventilation. That's the MBB, what is expected of the subject. So the BE increases with increasing work rate, but it doesn't max out. It doesn't reach MBB. So usually there's a 20%, okay, breathing reserve. That's the normal response. We don't max out our respiratory system. Unlike the cardiovascular system, we don't max out our respiratory system when we exercise. We still have 20%. Okay? Yung mga elite athletes lang ang nakaka-max out ng respiratory system nila. So that's X time. That's minute ventilation. Natin to. Okay? That's MBB. Okay, notice that the minute ventilation increases, but there's a breathing reserve here, more than 20%. And that's normal. Okay, more than 20%. Okay, let us analyze now the increase in BE response as far as the RR and tidal volume. How do we increase our minute ventilation? By playing with our RR and tidal volume. Okay, so during the initial part of the exercise, we increase almost simultaneously our RR and tidal volume. But at peak exercise, we increase more the RR than the tidal volume. Okay, so that's the BE response, RR and tidal volume. How do we analyze it? By means of this graph. X is minute ventilation, Y is tidal volume. Okay, that's the expected pathway of the tidal volume. Okay, so the tidal volume will increase linearly during exercise initially, but during the latter part of the exercise, the increase in minute ventilation is primarily due to the increased RR, and you see some plateauing of our tidal volume here. Okay, so time, tidal volume, expected pathway, and that's the pathway that is done by the patient. It's still in the expected path, plateauing a little bit early, but still acceptable. Okay, so we now go to the VE-BCO2 relationship. Okay, the carbon dioxide is eliminated by alveolar ventilation. So the higher carbon dioxide production, the higher should be our alveolar ventilation. And alveolar ventilation is the difference between minute ventilation and dead space ventilation. So if this is normal, there is a normal relationship between the minute ventilation and the carbon dioxide production. Okay? But if there is increased physiologic dead space ventilation, where does this happen? BQ mismatching, COPD, asthma. Okay? It's going to increase our dead space ventilation. Okay? The minute ventilation needs to compensate more to eliminate the carbon dioxide. And therefore, we're going to have a high respiratory equivalent for carbon dioxide. Okay, so this is how it's plotted in the software. X is time, X is carbon dioxide, Y is minute ventilation. That's the expected pathway for the minute ventilation. BeBCO2, I mean. X is time, X is carbon dioxide, Y is minute ventilation. That's the expected pathway of your respiratory equivalent for carbon dioxide. Okay, and the subject, okay, goes increase in BeBCO2 is within the expected pathway. So by just eyeballing, it is normal. Okay, if it goes outside here, you can deduce that there's increased physiologic dead space ventilation. Okay, we now go to the changes, the exercise tidal loop, which Bernice explained earlier. For you to understand it, let's review the different lung volumes. ITER, inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. ITER. Okay, the amount of air that goes in and out of our lungs is known as your tidal volume. It has two reference points, at end inspiration and at end expiration. If we inspire from end inspiration, we inspire maximally, the additional amount of air that we can inspire is logically known as inspiratory reserve volume. From end expiration, if we expire maximally, the additional amount of air that we can expire is logically known as expiratory reserve volume. The amount of air remaining in our lungs after maximal expiration is known as your LATAC or residual volume. Now, if we combine two or more lung volumes, we come out with capacities. And the acronym is TVIF. Total lung capacity, vital capacity, inspiratory capacity, and functional residual capacity. Okay. So, what are the four lung capacities? Okay. If you combine ITER, that's total lung capacity. If you combine I, T, and E, the upper of ITER, that's vital capacity. If you combine the upper two, that's inspiratory capacity. And if you combine the lower two, which is E and R, that's functional residual capacity. So, if you combine everything in total, that is total lung capacity. If you combine the upper three, that's vital capacity. If you combine the upper two, that's IC. Combine the lower two, that's FRC. So, Bernice mentioned inspiratory capacity. Later, you're going to see how the exercise tidal loop is made. So, the patient is breathing and the command will be, hingang malalim, hihinga siya ng malalim. And that is an inspiratory capacity maneuver. That is how we plot the exercise tidal loop in the software. Okay. So how do we increase our minute ventilation during exercise? Okay. So this is the breathing pattern at rest, light, moderate, and heavy exercise. How do we increase our tidal volume? What's the pattern? We recruit our IRB and we recruit our ERB. That's the normal response. Okay. So we can analyze the breathing pattern of the patient by the exercise tidal loops. Okay. It looks so at different stages, we do this expiratory force vital capacity, exercise force vital capacity, wherein we measure the exercise tidal loop. Okay. That's the purpose of this one. We do it during resting, warm up, and more frequently during the exercise proper. So the baseline spirometry is made, as mentioned by Burns. Okay, the one it's in gray. Okay, and the exercise tidal loop is plotted. That's the one in blue within the various times during the exercise proper. So let's discuss it further. Let's discuss the genesis of the flow volume loop. In the flow volume loop, the X is volume, the Y is flow. Inspiratory events are in the lower half, expiratory events are in the upper half. So initially, we ask the patient to do tidal breathing, and we ask the patient to inhale to TLC. Since it is an inspiratory maneuver, it is going below. The recording will be below. Once the patient is at TLC, we ask the patient to forcefully, rapidly, maximally expire for at least 6 seconds. And once we feel that the patient is at residual volume, we ask the patient again to inspire back to TLC. Now, the take-home message here is you should know the different lung volumes with this flow volume loop to analyze the breathing pattern of the patient. So from this point, that's point TLC, that's point RB. Okay, that's the tidal volume of the patient. So this is IRB from here to here, and that's ERB from here to here. Okay, so the exercise tidal breathing maneuver, okay, a baseline flow volume loop is done, okay, in gray. During exercise proper, the subject's exercise tidal breathing loop or the expiratory exercise flow volume loop, EFVL, is plotted within. Yan, yung blue. Okay? So, during this time, the subject inhales to TLC. So, mag-i-inhale siya to TLC. Okay? And the software is going to plot that exercise tidal loop. So, that's how it's plotted. You pay particular attention later on during the demonstration on how it's plotted. Okay? So, let's dissect it. Okay? That's the flow volume loop. That's the tidal volume of the subject. That's the IRB. That's the ERB. And this is the baseline tidal volume of the patient during exercise. Initially, it's blue, but after the maneuver, it turns into red. Okay. So, this is the baseline. Okay, and this is what the subject is doing when during exercise. So that's the normal, the one in blue. That's the pattern of normal. That's the baseline tidal loop in red, and the exercise tidal loop is in blue. Okay, normally part of the loop should be on the right side of the baseline. This is the baseline. There should be. It means that the subject is recruiting the expiratory reserve volume. Likewise, the loop does not touch the spirometry flow volume loop. Hindi siya dapat didikit dyan. Okay, that's the normal pattern. Okay, so this is a loop showing dynamic hyperinflation. What's abnormal? No part of the loop is on the right side, okay, of the red one. Means that he is not recruiting his expiratory volume. Hindi siya maka-expire maximally. May air trapping. That's why it's called dynamic hyperinflation. Now, this is an example of a flow-limited breathing pattern. What's abnormal? It touches, okay, the maximum expiratory flow. He should have gone higher, pero hindi niya kaya because that's his maximum. Okay? So, you want me to blow your brains up? Okay, so we now go to the last 3 bullets. Okay, so let's apply it. We have a 70-year-old ex-smoker, 20 years. Okay, progressive shortness of breath or since 50 years old, starting 50 years old, currently on MMRC1. Okay, 1 month prior to consultation, he was clinically diagnosed, no spirometry for COPD. He was started on a LABA ICS. Lumapit sa iyo for second opinion because he is not improving. You did a chest x-ray and there was a nodule. You had it biopsied and with a CT scan, it's a stage 2A squamous CL. And the flow volume and the spirometry is compatible with COPD. So the patient is for possible lobectomy. But always we try to screen the patient if he is going to tolerate pneumonectomy. So the predicted post-operative FEV1 with pneumonectomy is 30%. Okay. So the clinical question now for this patient is, what is the perioperative risk of the patient? Is the dyspnea of the patient due to COPD only, or is there a concomitant cardiovascular condition? What is the patient's level of functional impairment? Is it safe for the patient to undergo exercise training or enroll in a rehab program prior to surgery? Because there's good data that rehab before cancer surgery increases survival and better outcome. So you might want to do rehab in those patients. So here are the indications of CPET. I won't repeat what Bernice mentioned. And it is applicable in our patient. Okay, and these are the different, okay, complicated, okay, algorithm. And what I want to use is the simplified one for the ERS. Okay, let's dissect this one. Okay, the first question is it a maximal test? And these are the parameters. At least one RER of at least 1.05, peak heart rate 100% of the maximum, able to achieve the predicted VO2 or the VO2 plateaus, and no evidence of ventilatory limitation, with evidence of ventilatory limitation and a low breathing reserve. Okay, it's very important to know if the test is maximal or not. If the test is not maximal, you should interpret with caution, but still interpret it. But the interpretation should be correlated clinically with caution. So after that, you look at the peak VO2. Okay, if it is normal, okay, patient is healthy, or if the patient is really symptomatic, probably it's anxiety, or the patient has just a beginning mild disease. Okay, if it is low, the first thing that I look out for is a ventilatory limitation. What are the signs of ventilatory limitation? Abnormal exercise tidal loop, flow limited ba? Dynamic hyperinflation ba? Low breathing reserve, magic numbers 20. Is the RR too high, more than 50? Is there early plateau of the tidal volume? Is there a high BE-BCO2 slope? Is there desaturation? Okay. If there's none, then you rule out pulmonary vascular and cardiovascular and deconditioning. So for cardiovascular and pulmonary vascular, you look for abnormality in VO2 heart rate, VO2 work rate, low anaerobic threshold, flattening or declining of the VO2 heart rate trajectory, which is your stroke volume. Okay, abnormal heart rate VO2, which is likewise your stroke volume, abnormal blood pressure response, and ECG abnormalities during exercise. If it is present, then you're pretty sure it's cardiovascular, pulmonary vascular. Okay, if it is absent, you look at the AT. If the AT is normal, probably the patient is deconditioned. If it is low, it might be a muscle problem. Okay, so if there's, we look for the pulmonary problem with this parameter. If there's a pulmonary problem, we don't know if there's a concomitant cardiovascular problem. If there's no cardiovascular problem, okay, then it's pure respiratory. But we look for concomitant cardiovascular problem using the same parameters as on this side. Then we say it's a combined, the combined cause of the shortness of breath or exercise limitations, both pulmonary and cardiovascular. So this is the CPET report, okay, in the institution I'm affiliated with. We have the baseline spirometry. You have your tabular graph. You have here your Wasserman 9 graphs. We have a lot of exercise tidal loop. Then we only have less than a page of interpretation. Okay. So let's have a closer look at the tabular graph. Okay. So you have your metabolic parameters here. Let's take, for example, your VO2 over kilogram. And notice there's several measurements at rest, at warm-up, at anaerobic threshold, at peak exercise. What is expected of the VO2 for the subject is expected to have 23. You only produce 15. And that 15 is 66% of the 23. The normal should be more than 19. So the computer software plug it as a low VO2 over kilogram. Okay. Contraindications. There are no contraindications in our patient. So the patient underwent a CPET. Okay. So first question, is it a maximal test? Okay. Is the RER of the subject above 105? Yes, it's above 105. So you need only one parameter. It's a maximal test. Okay. Is the peak VO2, peak heart rate more than 100%? No, it's not. It's only 64%. Did the patient achieve the predicted VO2? No, he did not. It's low. Are there signs of ventilatory limitation, breathing reserve of less than 15 and or significant exercise flow volume loop, air trapping of dynamic hyperinflation? Okay, so you can see here that the flow volume loop, what's this? Is that dynamic or airflow limitation? Okay, this blue one is not on the right side. That's dynamic hyperinflation, and it touches the flow volume loop. That's a combined dynamic hyperinflation and a flow volume loop, and dynamic hyperinflation and a flow limited breathing pattern. So the test is maximal. You can rely on it. Okay, the next thing is you look at the peak VO2, and we look at the ml per kilogram per minute. Okay, in the subject, the maximum is 15.4. Expected is 19.5. It is low. So it is low. If it is low, we look for ventilatory limitation and gas exchange abnormalities. Okay, what are the parameters? Is the breathing reserve less than 20%? It is not less than 20%. Okay, it is more than 15% yung ginamit nila dito. 15%. Okay, there's no low breathing reserve. Okay, so the respiratory is greater than 50. Okay, it is 41. Is there a high BCO2 slope? Yes, there is a high one. Okay, is there desaturation? There's no desaturation. Is there early plateau of the tidal volume or abnormal exercise tidal loop? Okay, you notice this is the tidal volume. It goes in within the pathway, but it plateaus early here. So there's early plateau of the tidal volume. And again, you see the exercise tidal loop. That's dynamic hyperinflation, flow limited breathing pattern. So you're definite there's a ventilatory dysfunction impairment in the patient. So you have to rule out cardiovascular or pulmonary vascular limitation. Okay, so we take a look at the VO2 heart rate. It's normal. We take a look at the VO2 over work rate. It is low. We take a look at the blood pressure and the ECG abnormalities. It is normal, the blood pressure. The ECG is also normal. We look at the anaerobic threshold. It is 65% normal. We look for flattening of the VO2 heart rate or abnormal heart rate VO2 slope. Okay, you can see here, it is increasing and it surpassed, okay, the VO2 heart rate. So it's normal. So there's only one parameter that's abnormal. So I won't consider that significant. So I don't think the patient, based on this result, has a significant cardiovascular problem. So it's purely respiratory. Okay, so let's go back to the clinical question. What is the perioperative risk of the patient? This is ACCP. The predicted post-operative pneumonia FEV1 is less than 30%. We do a CPET, and what we got was around 15, right? So 10 to 20, 15 is moderate risk, but in heart center, that's still considered normal, right? Okay. So what is the dyspnea? Is the dyspnea of the patient due to COPD? Yes, you ruled out cardiovascular disease. Okay, what is the patient's level of functional impairment? At 15.6, that's moderate impairment. Is it safe for the patient to undergo exercise training to enroll in a rehab program prior to surgery? Yes, there was no adverse effect when we max out the patient. There's no need for the patient to use oxygen when he undergoes rehab. And you may use the target heart rate above 80 for endurance training, as will be discussed later on. So in summary, okay, simplistically, CPET physiology increases the VO2 and there are changes in the minute ventilation and the cardiac output. By analyzing this particular pattern, we can use the CPET in the interpretation. It's finally over. It's done. Thank you very much for your attention.
Thank you, Dr. Tim. Grabe, no? It's very simple. Basta si Dr. Tim ang nag-lecture talaga. Dr. Punzal?
Okay, Tim, thank you very much for that excellent lecture. Actually, I am the one who personally invited him to join our workshop, hoping to convince him, and he will not decline. And this is the lecture that you got now is precisely the reason why we got him as our lecturer. Understandably, it is a difficult thing, a lecture to make, and sometimes a difficult lecture to digest. Okay. Earlier you said that are they ready to vomit or are they ready to blow their brains? No. Can we have that video? Okay. What I did was just while you were lecturing, I took a very short video. It's an 18-second video of our audience, and we would like to see for yourself. Ano ba yung reaction nyo, ha? Habang nagle-lecture si Dr. Tim. Okay. Okay, so you can just...
You're going to use aerobic metabolism. But if it becomes inadequate, you're going to recruit the anaerobic metabolism. Notice that during aerobic metabolism, we use oxygen, we produce ATP, but we produce carbohydrate, you're going to use aerobic metabolism. But if it becomes inadequate, you're going to recruit the anaerobic metabolism. Notice that during aerobic metabolism,
Okay, so actually nobody vomited. At least that was one we were able to document. But no, I can see now there were some difficulties. You cannot learn expired gas analysis in one sitting. You will have to devote some time, and you have to have mentors like Dr. Tim in order for you to be able to grasp the very essence of what expired gas analysis, VO2 max, anaerobic threshold is all about. And we really appreciate the efforts of Dr. Tim for bringing us to light the very essence and the important concepts of expired gas analysis. Thank you, Tim.
Thank you, Percy, for those kind words. For your information, when I was still a medical student, I was a resident. Percy came into our institution and lectured on VO2 max. He just came from University of California, San Diego. He's the father of pulmonary rehab. Okay, so when he lectured that, it was Andy Rees who taught him how to interpret CPET. So when I went there, It's also Andy Rees who taught me how to interpret a CPET. Okay? So you cannot really get it the first time. It needs a lot of reinforcement. You really got to be interested in it, and you got to know physiology. Kung pattern lang, mahirapan kayo. You got to know physiology because algorithm interpretation, well, it simplify everything, but there's such a thing as physiological interpretation of the CPET. Okay?
Okay. Now, I know that some of our machines will have automated interpretations. Okay. For those of you with machines, probably you have seen this. We discourage the use of automated interpretations. What you have to do is go through the data that you can see in the 9 panel. The most important ones are actually the oxygen consumption, which can be interpreted as liters per minute or ml per kilo per minute, and the anaerobic threshold. The rest are additional informations. And in terms of perioperative examination of patients, this is a very useful tool, especially for those with borderline numbers in your initial evaluation. There are a number of other uses of CPET. You can use this for disability. You can use this for rehab and for other purposes that it may serve. Okay. Tim?
Yeah, I'm good. I'm hungry. So
So thank you again, Dr. Tim. Ang sabi nila, if Dr. Punzal is the father of pulmonary rehabilitation in the Philippines, Dr. Tim Trinidad is the uncle daw. Okay, so we end this morning with Dr. Tim's lecture. So we'll be having a 1-hour break. Okay, you'll be having your lunch. So at 1 p.m., we'll be dividing the group into 2 groups, no? So yung isang group sa second floor for the field walk test, and then the other